All right, let's talk about a condition that has, without a doubt, one of the most intense reputations in all of medicine, trigeminal neuralgia. Now, the name itself might not ring a bell, but its historical nickname, the suicide disease, well, that tells you pretty much everything you need to know about how severe this is.
To really get why, you have to start with the pain. And these words, this isn't some dry description from a medical textbook. Nope, these are the words that people who actually live with this use to describe it. This isn't just a bad headache, it's a full-on sensory explosion that's been called one of the most painful conditions known to humanity.
And that intense, unimaginable suffering is exactly how the condition earned its horrifying nickname. Back in the early 20th century, a famous neurosurgeon named Harvey Cushing, he was one of the first to really document the sheer despair his patients felt, which is what cemented its reputation as a condition that was, for many, almost impossible to live with.
So what on earth is happening inside the body to cause this level of pain? Well, that takes us to the anatomy of an attack. You can think of it really as a biological short circuit happening right in your face.
It all comes down to the trigeminal nerve. This is one of the most critical nerves in your head. It's the reason you can feel a gentle touch on your cheek or the cold of winter air, and it also controls the muscles you need for chewing and biting. Pretty important, right?
And this nerve isn't just one single line. It actually splits off into 3 major branches that cover different territories of your face. You've got one for the upper part around your eye, another for the middle section, think your cheek and upper jaw, and a third that runs along your lower jawline. The pain can hit any one of these zones.
Okay, so here's the absolute heart of the problem. The nerve's protective coating, which is called the myelin sheath. The best way to think about it is like the plastic insulation on an electrical wire. In a healthy nerve, that insulation keeps all the signals moving smoothly. But with trigeminal neuralgia, that insulation gets worn away or damaged. Suddenly, you have a stripped, raw wire where signals cross, they misfire, they short-circuit, and that creates this agonizing electric pain from even the slightest trigger. So what's causing that damage? Well, the number one culprit is usually compression. Most of the time, there's a blood vessel, often one called the superior cerebellar artery, that's pressing right up against the nerve. Day in and day out, that constant pulsation just wears down the myelin. Other things can cause it too, like damage from multiple sclerosis, or a tumor, or even physical trauma. But that rogue blood vessel, that's the classic cause.
All right, so if we know what's likely causing it, getting a diagnosis should be pretty straightforward, right? Not so fast. This is where we run into the huge challenge of diagnosing an illness that you just can't see.
And this is a really critical point. There's no blood test, no simple scan that can pop up and say, yep, this is trigeminal neuralgia. The diagnosis is almost entirely based on the patient's story, what the pain feels like, what triggers it, how long it lasts. This can lead to a really long and frustrating journey, with patients often being misdiagnosed and feeling like no one believes how bad their pain really is.
Telling it apart from other conditions is absolutely key. For example, it's often confused with TMD, which is a problem with the jaw joint. But the pain is totally different. TN is that sharp electric shock from a light touch, while TMD is more of a dull, constant ache you feel when you chew. And here's a big clue for doctors. A nerve block can temporarily shut down TN pain, but it won't do a thing for the muscle and joint pain of TMD.
Now, a tough diagnosis does not mean there's no hope. Far from it, actually. And that brings us to the pathways for relief, which cover both medical treatments and surgical options.
The game plan for treatment is usually very methodical. You start with what are called first-line medications. These are typically anticonvulsant drugs, and they work by basically calming down those hyperactive, misfiring nerve signals. If those don't quite cut it or the side effects are too much, doctors will try other drugs. And for the really tough cases that don't respond to medication, surgery becomes a very real and powerful option.
And that first step, it's incredibly effective for most people. The main first-line drug, carbamazepine, gives significant relief to about 90% of patients when they first start it. Think about that, 90%. For someone who's been in the depths of this pain, that's a huge beacon of hope.
So for that other 10% or so who don't get lasting relief from meds, surgery is the next stop. And when it comes to surgery, there are really 2 main philosophies. The first is non-destructive surgery. The goal here is to fix the root cause, that pesky blood vessel, by carefully placing a tiny Teflon sponge between it and the nerve. The other approach is destructive. Here, the goal is to intentionally injure the nerve just enough to stop it from sending those pain signals. It can work really well, but it does come with a risk of permanent numbness in the face.
So let's just recap how well these things work. The initial medication gives relief to about 90% of people right out of the gate. And even for those who do end up needing surgery, the outlook is still really good. That non-destructive surgery, microvascular decompression, gives relief to about 75% of patients who weren't getting help from the drugs.
But statistics and treatment plans only tell one part of the story. What is it actually like to live with this condition day to day, when the threat of an attack is always just there? Let's talk about that daily impact.
What is so unbelievably devastating about trigeminal neuralgia is how ordinary the triggers are. Just try to imagine being afraid to talk, to eat your favorite meal, to brush your teeth, or even just to feel a light breeze on your face. The simplest, most basic parts of being alive suddenly become these minefields of potential agony.
And that unpredictability, that's the real monster here. It's not just about the pain itself, but the constant crippling fear of the pain. That takes a massive psychological toll, leading to really high rates of anxiety and depression as people start to withdraw from their lives, absolutely terrified of what might trigger the next attack.
This has been a long, long battle. The condition was first written about way back in 1773. More than 100 years later, Cushing's work finally shined a light on just how severe it was. But the story today is genuinely one of progress. We understand so much more about what causes it, and we have treatments that were completely unimaginable just a few decades ago.
And that really brings us to the final thought. Trigeminal neuralgia is by its very nature an invisible illness. You can't see the damaged myelin sheath. You can't see the artery pressing on the nerve. All you can see is the person suffering. And it kind of leaves us with a bigger question, doesn't it? In a world that's so full of invisible struggles, how do we get better at seeing, and more importantly, at believing the pain of others?